So I can't avoid the feeling the clap is slightly ironic because I am an hour late and I'm sorry about that. I apologise. You'll notice the title is subtly different from your programme. It says MRI after preterm birth ? And I was asked to provide questions, so that's the question. And you can answer it yourselves as we go through or later. So we're familiar with using this. This is ultrasound. All of us use it on a daily basis, and it's extremely useful. It's reasonably productive of giving you information for what the future of a given child is. And if you look at the actual prognostic value of ultrasound, then it's reasonably good. This is a Bayesian analysis, which means we start off from the belief that around 9% or 10% of our children will have cerebral palsy when they grow up. That's based on the EpiPage study, which I still think is probably the best data around. And if a child's got a normal scan, then instead of the sort of 9 or 10% risk they have, it'll fall to 4 or 5%. And that's pretty good. Very tight confidence limits. We can be very accurate about that. So normal ultrasound scans are good for you. If you've got a grade 1 or a grade 2 hemorrhage, then it goes up to around 10% with slightly wider confidence limits. So in other words, a child with a germinal matrix hemorrhage has the population risk of cerebral palsy when they grow up. Grade 3, it's about 25%, grade 4, 50%, cystic PVL, 75%, and those are nice, easy numbers to teach the juniors. What you'll notice, though, is that these confidence limits for these higher grades of disease are very wide indeed. In fact, so wide, you have to question whether you should use these data. And the reason for that is that the world literature is not very full of children with these lesions in them. And in fact, when we did the meta-analysis, we found quite a lot of papers which had reported the same patient twice, which is naughty. So, what about MRI? MRI, look at it, isn't it beautiful? Look at the anatomical resolution. Look at the glorious detail you can see there. It's fantastic, it's wonderful. Isn't it great? It must be better, mustn't it? You can see where I'm going with this. You can see things you can't see on ultrasound. You can see white matter disease, which you can suspect from ultrasound because you can sort of see the ventricles getting bigger, so you think, well, something must be shrinking, it can't be right. So you can see white matter disease, and you can see things we've never dreamed of on ultrasound. You can see punctate lesions. You can't even see these on pathology because you can't find them. But they're visible on MRI very clearly. So MRI clearly picks up things that you can't see any other way. It must be better, mustn't it? The trouble is that it's a very expensive technique. It's very powerful but very expensive. It's quite an imposition for parents. They don't like having their baby taken off the unit very often to go and have a scan, or indeed coming back from home to have a scan. It might be that we pick up things that are visible on MRI but not important and just cause a lot of worry. So we don't really know whether MRI is better or not, and we need that classic medical intervention. We need a clinical trial to decide whether it's the right thing to use or not. So we did one. The evaluation of preterm imaging trial was £2 million of British government money to work out whether the country should invest in MRI. It used randomised and non-randomised components to evaluate whether MRI imaging after neonatal intensive care, as an addition to ultrasound, improved outcomes. It did a whole series of things, but probably the most important it did was, first of all, to determine with high specificity and high sensitivity the precision of ultrasound and MRI in a randomised trial to work out which one was better for predicting the future and which one was better for informing parents. And critically, for an imaging trial, you have to have a patient-orientated outcome. You have to know whether it's doing more harm or good to the family. So the primary outcome for the trial was maternal anxiety. And we did a few other things as well. So these children were referred from their hospitals in northwest London, 14 hospitals in northwest London, to come to a specialist imaging facility. And when I say specialist, I think what I mean is we knew what we were doing. At least I think we knew what we were doing. And we did ultrasound and we did MRI, and we randomised the parents to receive one piece of information or the other. It was very interesting going to the ethics committee about this, because when you go to an ethics committee and you say, we'd like to give a patient a drug or a placebo, then that's fine, they understand that. But the idea of giving a piece of information and withholding a piece of information sent them into a real flurry. It took a long time to get the idea that a trial of information was a valid thing to do, but eventually they agreed to it. And we did all these other things as well. The outcome measures for the trial Neurodevelopmental outcome at the age of 20 months. You can see the list of things we did there. Maternal and paternal anxiety, measured at 4 time points through the trial. And then a series of economic and financial outcomes, including total societal cost and the cost of doing the MRI scan. So we tried to assess whether doing the MRI was the right thing to do in a whole series of ways, randomized and qualitative. And as our prognostic value, we chose the categorization that came from Terry Inder's group, because this is the one which is advertised most widely across the world as being the way to do MRI analysis. Now, there were various sub-analyses which didn't use this to check that, because of course this may not be a very good analysis, it's possible. But we use this one because this is the one people use, especially in America. So we categorized our MRI images using this form of analysis, not one that we'd made up ourselves. And this is the consort diagram for the trial. And it's a kind of strange consort diagram because you'll notice that it starts off with recruitment, splits into the trials group, then joins up again at the bottom. So just going through it very briefly, we assessed 3,500 children in northwest London for eligibility and managed to recruit about 662 of them, of whom only 511 ended up in the trial, mainly because the parents withdrew. And I think the fact that parents withdrew is quite important. It tells you that coming for an MRI scan is a burden on the family. And I think that's something which gets lost in a normal trial analysis. Those 511 children were randomized. One family dropped out for complicated reasons. And then we had 200 families in each group, roughly, and slightly more children. And that's the randomized component. That's where we assess the maternal anxiety and all the other secondary anxiety measures. But then the trial comes together again, and we do a diagnostic evaluation using all 500 of them. So this is a well-powered trial to do diagnostic evaluation. The children we recruited are fairly typical of your neonatal unit and my neonatal unit. They were under 32 weeks of age, and the gestational age distribution is like this, which I think you'll agree is fairly familiar to us. The birth weight distribution, again, these are skewed towards the slightly bigger babies, but there's a fair number of smaller babies in it, so it's not as if it's all 32 weekers. And in terms of sickness, I just show you the ventilatory support numbers. This is the amount of days on CPAP, or the number of days ventilated for the trial group. And again, I think you'll see this as a familiar representation of the kind of children that we deal with. So I would contend that this is a characteristic group for neonatal intensive care across the developed world. These are the results. First, ultrasound. So the sensitivity and specificity of ultrasound is pretty much what you would expect. It's highly specific, 97% specificity with very tight confidence limits, but very insensitive, only 30% sensitive. So you're going to miss a lot of babies with ultrasound. That's not actually, though, what you really want to know. I know that's what everyone talks about, but actually what you really want to know is when you've got a family in front of you, what can you say to them? And for that, you don't need the sensitivity and specificity, you need the positive and negative predictive values. So, got the slides in the wrong order. Let's do MR. So MR population values, actually they're slightly better for sensitivity, but they're worse for specificity. So it's not quite as specific, but it's more sensitive. So back to what we really want to know, which is the positive and negative predictive values. So for ultrasound, the positive predictive value for cerebral palsy is around 50%. You might as well toss a coin, actually, to decide whether the child has cerebral palsy or not, in terms of positive predictive value. Negative predictive value, if it's a normal scan, actually that's pretty good, as we said earlier. So those confirm what we know from the literature. MRI, well, look at the positive predictive value of MRI. It's worse than ultrasound. Actually, it's not worse than ultrasound, it's just the confidence limits are so wide for both that it randomly comes up. It's actually very poor. So the positive predictive value for cerebral palsy for MRI is actually very poor. It's highly specific and has a high negative predictive value, but it's very insensitive and you have a low positive predictive value for a bad outcome. You cannot use MRI to tell a family whether the child's going to have cerebral palsy with any high level of precision. Are the tests different from each other in a global sense? Well, the way people assess tests is to look at the area under the curve of the receiver operator curve. And actually, technically, MRI is better than ultrasound. Thank God for that. in assessing the GM-CSF and the Bayley motor domain. But actually, both of those areas under the curve are so low that actually they don't really give you the kind of test you want. And the confidence limits, again, are quite wide on that. This slide, I think, makes the point. This is the raw data comparing the prognostic score from MRI to the Bayley motor score. Now, you'll notice immediately that there's a trend here. There's no doubt that MRI picks up the trend of outcome. But take one individual value, take the value prognostic score of 10, which is, reasonably bad. With a prognostic score of 10, the child might have anything between a motor score of about 55 and a motor score of 115. That's why it's not a good predictor. It's good at picking up the trend, so it's a population research tool, it's fine. But for individual families sitting in front of you, it doesn't work. So let's just ask ourselves, what does that mean in practical terms? If we're trying to use MRI to talk to families, we can see that's not very helpful. How about using it to run our neonatal units and run our follow-up programs? Can we use it to select children who need to come to follow-up? Well, if you use the data in this trial, then the MRI would have selected about 15% of all your survivors to come to follow-up. Well, given that 10% have cerebral palsy, that sounds pretty good. The trouble is that only a quarter of those would have actually had a moderate or severe functional deficit. So 75% of those you select won't have that problem. It will miss at least a third of all the children who have neuromotor problems. It really doesn't work as a way of selecting children for follow-up programs. So it's no good for talking to families, and it's no good for running a follow-up program. What did it do to the families? Well, I'd be interested to know what people think, actually. I can't ask, this is published now, so I can't ask the question anymore. But when I asked people what they think before the trial, then most people thought that MRI would cause more concern in the parents than ultrasound. And that was a reasonable guess, that actually the numbers of lesions that we see, the punctate lesions, the white matter lesions, might actually cause a lot of concern in the parents and make them worry more than if they hadn't had the ultrasound scan. But when we actually looked at it, it was quite interesting. This is the baseline level of anxiety in mothers. This is the STAI state anxiety measure. It's a very well recognized measure of anxiety used across the world. And roughly, if you're below 40 or 42, then actually you're regarded as normal. Above that, you're getting fairly anxious. So what you can see from this is that actually, slightly surprisingly, most of the mothers who came to have their children scanned were not very anxious. They were actually perfectly okay. There was a tail of them, who are clearly anxious, but most of them are not terribly anxious. They're mostly within normal limits. What happened to them after they had the MRI scan result? Well, these are the anxiety scores for mothers who had either data from ultrasound or data from MRI fed back to them. And what you can see from this is that, well, two things. One is that the mothers who had the MRI data are less anxious than those who had the ultrasound data. But the second thing you can see, if you look at the y-axis, is that these are all low values. These mothers are almost all in the normal range. So yes, there is a slight change in anxiety in mothers after an MRI scan, and it's to the good. It's great. It makes them less anxious. That's fantastic. But actually, it's all in the normal range. We are neither making parents concerned or frightened by the MRI scan, but we're not doing them any good either, not in any real sense. So these are not very helpful if you want to make a better clinical tool. If you're a researcher who wants to use MRI, this is the data you show to say that it doesn't do any harm. The anxiety the mothers had was unaffected by how long their child had been in intensive care, unaffected by how severe the illness was that their child had, which we measured in terms of days of ventilation or episodes of neck and things like that. It was unaffected by how premature the baby had been. So they're quite robust against all those phenomena. However, the one thing that did show up as an interaction was that if the MRI scan was abnormal, then the mothers were more worried. Now that's actually a very coherent picture. If you have a normal scan, which most of these scans were pretty normal, then the mothers feel great because they've got the high resolution image to look at and it makes them feel better. If on the other hand it's an abnormal scan, which does have a bad predictive value in some way, then of course it's very obvious to them that's bad and it makes them more anxious than the ultrasound, which is less obvious and less compelling to look at. So in terms of anxiety for the mothers, this does exactly what you might have thought it would do, which is it's reassuring when it's normal and it's more worrying when it's abnormal. And the reason the overall level of anxiety comes down is because most scans were normal. What about the cost between the groups? Well, there was no difference in healthcare usage between the groups. So one hypothesis for the study was that if the mothers were more reassured by the MRI scan, they would go to see their doctors and their nurses less. That didn't happen. It was the same across the groups. There was no difference in the health-related quality of life that the two groups had. There's nothing that made the mothers more happy, that made them use less healthcare or feel better about their baby. It was about the same. Interestingly, and I commend this piece of information to all the men in the room, the fathers were completely unaffected by everything we told them. You can make of that what you will. And one important thing, this trial was done comparing specialist MRI and specialist ultrasound. So we had people doing just one scan at the term. It was quite important to know the ultrasound didn't produce a different result from the normal routine serial ultrasounds that we all do in our units. And in fact, we tested that. There was no difference in outcome prediction between the serial ultrasounds from the unit and the single ultrasound from the trial. What about the costs? Well, MRI is expensive actually, but not as expensive as you might think. The actual cost of a single MRI scan when we did the trial, and it's not that different now, was about £700. So that's about 500 euros these days. Work it out. So that's not as much as people think, and it's not as much as you're probably charged by your radiology departments either. So if you want the data on this, I can give it you afterwards. The cost of a ultrasound scan, a single ultrasound scan, is quite cheap. But actually the cost of doing routine ultrasounds the way we do it is actually quite expensive because we use doctors' time repeatedly to do it. So the cost of repeated ultrasound scans is actually around £500. So the difference is actually about £300 between the two modalities. You could either do ultrasound or MRI, and you'd have about the same, about £300 difference. If you look at the total healthcare costs of the two groups, there was very wide variance in the groups, and there was no significant difference between the two. So the take-home message of the cost analysis is that MRI will cost you about £700 to do a single scan. So how do we interpret this? Well, I think the interpretation is really quite straightforward, which is that routine MRI for preterm babies less than 32 weeks is not really, in any practical sense, better than ultrasound. It doesn't really add very much. Neither ultrasound nor MRI will allow you to select children for a follow-up program effectively. And again, this is telling us that we should follow all our children up, which is not a new message, but it's one that we have to keep on, I think, telling our managers. Surprisingly, most mothers had fairly normal anxiety before they came to the scan. I think we're fairly used to families coming through our units and having a very tough time and being very anxious, having major psychological upsets. By the time they go home and come back and do a test, actually they've recovered. That's what the implication of this is. MRI does reduce maternal anxiety slightly, largely because most of the scans are normal. But if the scan is abnormal, it makes the mothers more worried. Now, you might argue that's a good thing or a bad thing, depending on what you think the best thing for the family is in terms of knowing the truth about outcomes for their children. MRI doesn't improve health-related quality of life, and it doesn't reduce healthcare resources, and it will cost you about £300 per patient to do the study. So that's the basic analysis. That's where you start if you use ordinary MRI as promulgated in the literature to do a routine study of your preterm babies. But there are other things you can do. And there are other analyses you can make to see if you can use it more usefully. So the first thing to say is there an improved scoring system? Can we do better than the widely used Woodward system? So the answer is we've tried that, and no, we can't. We can't find a better one. We can make a marginal change, but not a very big one. What about the other lesions, the ones that aren't included in that scheme? And the punctate lesions is the obvious one, and we'll come to those in a minute. And then, just in case you're getting really depressed, and I've worked quite hard to make you depressed, then there is some optimism coming, just to tell you. And it comes from different types of imaging and different types of analysis. And the spoiler for this is fundamentally we're looking at the wrong thing. We'll come back to that. So, punctate lesions. So, those of you who look at MRI scans of preterm babies, and I'm sure many of you do these days, punctate lesions are these things that turn up in around, depending on when you do the scan, 25 to 30% at 30 weeks and about 10%, 20% at term. They're anything from just one little white spot or one little dark spot, depending on the sequence, where you see it in the brain, can be anywhere, to great numbers of these spots which seem to coalesce and almost look like PVL. So a wide range of phenotypes for this disease. It's invisible on MR, and no one's really convincingly found it on pathology yet, although some people think they might have done. So do these lesions predict outcome? Well, the answer is yes, they do actually. Oh, I've become disconnected.
What happened there?
It's not a good day, is it? Try again? No? Okay. I can shout, that's any good. Okay. Is it the battery or?
No, I think it's the cable. I don't know what happened, but that's how it is when we go live.
Yeah, okay. I feel a bit like Beyonce, actually. Okay.
See you. Yeah. Here you go.
Testing. Right. Good. I have to say that was the slickest piece of A/B technical work I've ever seen. Thank you very much. So punctate lesions actually do predict outcome. If you see punctate lesions, then I'm afraid I'm one of the people that used to say they're probably not predictive, they probably don't mean anything. I was wrong, they do. And actually they do predict cerebral palsy with reasonable precision. And you can see here that the sensitivity and specificity of any punctate lesion is actually almost the same as the entire white matter score we looked at earlier. The positive predictive value, though, is very low. You can see that. And the negative predictive value is quite high. So it's rather the same story as with the overall score. If you see punctate lesions, yes, they have a relationship to outcome, but in terms of talking to individual parents and individual patients, it's not very strong. So, where's the optimism coming? What can I tell you that isn't boring, tedious, and depressing? Well, the answer is that we're looking at the wrong things. We are trying to use MRI as an ultrasound machine. We're trying to replicate ultrasound because that's what we think brain injury is. We think it's an ultrasound appearance. And that means because we're looking at the wrong thing, we're getting the wrong answers. And we need to start again and rethink what preterm brain injury is. Think back to the history of this. The history of understanding brain injuries in the preterm is that first of all the pathologist found blood in the ventricles, then the pathologist found PVL, and then we found an imaging method to go and look for those two things. And it's quite good at finding blood, it's reasonably good at finding PVL, but actually then we stopped. And although over the years people have kind of understood that blood in the ventricles isn't the end of the story, and that PVL may be not the only lesion that happens in white matter, who talks about grey matter? when you talk about preterm brain injury. And yet the cortex in preterm babies is 10% smaller than it is in term babies. Who talks about the thalamus? The overriding imaging finding in preterm babies is a small thalamus. Who talks about the cerebellum? Well, we'll come to that in a minute. So we're looking for the wrong things. We're looking for the wrong lesions because our history has confined us with the wrong set of ideas. So let's start again from scratch. Let's start with no prior knowledge about what we're expecting to see, and let's see what we find. So I'm going to show you now the unbiased machine learning analysis of exactly the same data that you've just seen. And this will not produce for you a magical rabbit from a hat, which allows you to use MRI to predict the outcome of your babies. But I hope it will give you the beginning of a skepticism about how we think about preterm brain injury, which in my view is long overdue. So what you see before you is a machine learning analysis of the same data. And for machine learning, just think of nothing more simple or more complicated than just clustering. All you do is you cluster features together. All the machine learning algorithms do is cluster features together. Things which are statistically aligned. Are we still going? Yep. Things which are statistically aligned are put together. And this machine learning analysis took all the imaging features that are in the images, not just the ones you see with your eyes. And that's the other problem, of course. We are looking at things with our eyes. But all the features that are there. Let me just, to make this point, let me just make a small diversion into a different subject. There's a very good paper just come out about 6 months ago from DeepMind. DeepMind are the machine learning company that beat the Go master at playing Go. I'm sure you saw the news. Very smart people. They did a machine learning analysis of optical coherence tomography data from ophthalmoscope, from ophthalmology in diabetics. And fundamentally what they found was their machine learning, their non-biased, use all the data analysis of these scans was about the same as a trained ophthalmologist in most cases, as long as one thing was true. If you gave the ophthalmologist clinical data on the patient and told them the age, blood glucose, this sort of stuff, then the ophthalmologists were as good as the machine learning. If you didn't do that, the machine learning was better. Now, why is that? It's because the machine learning is doing things that humans aren't doing. It's using data humans can't see. When you look at images like the ones you see in front of you, we display them as if they are anatomical specimens, because that's what we're expecting to see. That's not how they come out of the scanner. The MRI scanner does not produce pictures of brains. It produces a series of numbers. It produces a data vector. And the data vector is then transformed through a whole series of more or less understandable processes to make it look like a brain. It's not a brain. It's a series of numbers. What machine learning does is to use the raw data at some level of rawness, and we can argue where that should be, some level of rawness rather than the final images, and uses those to make its analysis. So it uses data we cannot see. That's why machine learning is powerful. So with that background, what you see in front of you is the machine learning analysis of the data from the trial, and it's related to very simple clinical factors, of which the overriding clinical factor is gestational age when the child was scanned. So the graph on the side shows you the clinical features, and you can see from the small blue, I hope it's blue, I'm actually very colorblind. Is it blue? Yeah. The small blue or purple or whatever color it is thing, that's the relationship between the imaging features you see and the gestational age when the child was scanned, age at scan. And what the colors on the images show you, the pseudo images, because they're not really images, the pseudo images, is the relationship between the outcome, mainly age at scan, and the brain image. And the blue ones are when there's a negative relation, and the sort of bright colored ones, says he carefully, are the positive relationships. So what you can see is one label volume. So a positive relationship between volume and the age at scan. The brain's getting bigger. No big surprise there. T2 intensity, that's falling as the child gets older. That's expected. MD down the bottom, mean diffusivity, that's it's usually a measure of cell packing. So you see in the thalamus in particular, as the child gets older, the cell packing gets tighter. and FA we won't worry about at the moment. So that's a fairly simple, straightforward analysis. But that's only one clustering. There are many other clusters, about 4 other clusters, which turned up in the machine learning as being relevant to these images. And these are 2 clusters which are related to clinical features which basically relate to antenatal and postnatal events. So the top one is a series of events which are antenatal in origin. So in this cluster, for example, was having a longer gestational age at birth, so longer time in utero, higher maternal blood pressure, preeclampsia, maternal bleeding, and IUGR. And you see a whole series of features there which are related to those characteristics. And actually, we underestimate what happens to our preterm babies before they're born. There are huge amounts of changes in the brain happening to the children before they're born. These are all preterm, don't forget. This is not IUGR in term babies, this is all preterm. So this is added on to the effect of prematurity. So our preterm babies are already undergoing adversity before they're born. The one I want to talk about, though, is the bottom one, number C. This is actually the relationship between a series of clinical characteristics which are basically postnatal and the imaging characteristics. So what you can see is that the relationship is quite tight, and days of ventilation accounts for a fair amount of this relationship. So the longer they're ventilated, in general, the sicker they are, then these images are characteristic. And what you can see from the images are 2 things. First of all, that there's actually very little evidence of widespread white matter damage in this clustering. Despite what we all talk about in prematurity and premature brain damage, actually there is some localized change in the white matter, but it's not widespread. That's much more prominent in the antenatal features. But look at the cerebellum. You can all spot the cerebellum, can't you? Yeah, good. The cerebellum is the most obvious change in these images. And yet we hardly ever talk about the cerebellum in preterm brain injury. The thalamus is the next most obvious thing. That's actually well known. It's well known the thalamus doesn't grow in preterm babies. It's well known the connectivity from the thalamus to the cortex is underdeveloped. So that's not a surprise. But I present these to you to make you, I hope, to try and persuade you that we are looking for the wrong things with our ultrasound scans, and we're looking for the wrong things with our MRI scans at the moment. We need to look for different things. And when you start without any preconceptions, this is what you come up with. Cerebellum, thalamus, and there's a few other stuff as well, which I won't bore you with. So where do we go from here? Well, MRI actually is very powerful. It can do a lot of things. It can do far more than just try and repeat an ultrasound scan. It can look at brain function, which I'm not going to talk about actually. It can look at brain connectivity, and this emerging tractogram here, this is the white matter, the major white matter tracts in just one child's brain, imaged in about 10 or 15 minutes in an MRI scanner in a preterm baby. These kind of data are now available in large numbers across the world. We actually run a project which will make about 1,000 brain images available to anybody who wants to use them in a few months' time to analyze this kind of data. So this kind of information is now there to be used, and yet we never use it predictively in general. We should be thinking again about how we go into this kind of data set to use it for medical purposes in our neonatal units. Those overall tracts can be dissected in a lot of different ways. I'm just going to show you a couple of things now which are beginning to, I think, point the way to where we might start thinking about what brain injury really is. You can see here the tracts from the cortex on the one side. I'm not going to talk about those, but I will just take a look at what the single tract, the single virtual dissection on the right-hand side of the screen shows. This is the Arcuate Fasciculus. The Arcuate Fasciculus actually joins it's very involved in the language, and it joins Wernicke's and Broca's area, among other things. So with that tract dissected out, we can ask very specific questions. We think this is to do with language. We think it involves how a child will learn to speak. What relationship does it actually have to the child's real future? Well, actually there is a relationship based on the quality of that tract. This graph here is the relationship between the FA of that tract, which we've just dissected out, and the child's ability to speak when they're 2. Now, I'm not suggesting to you for a minute that this is prognostic value to tell parents about. This is not something that gives you a tool for the clinic, but it is a pointer to the kind of things we should be asking of our images. Rather than have they got spots in the centrum semiovale, we should be asking about specific tracts and specific functions. You can see the 2 tracts labelled there. In case you think this is just a feature of the whole brain, that the whole brain determines whether the child can speak, you can pick out other tracts which don't have the relationship. So these are the bottom, it's the superior longitudinal fasciculus. On the top, it's the corticospinal tract, neither of which predicts language function at all. And there are many other ways of looking at this. These are the same sort of data, rather older now, looking at the relationship between hand-eye coordination when a child's 2 and specific regions of the brain. So these are much more subtle questions that we can ask using our MRI scans, and this is where we should be thinking about going. We can start to put together these global connectomes of the brain. A connectome is a rather strange idea. It comes from genomics, of course, the idea that we know all the genes in our cells. The connectome is the idea we can learn all the connections in our brain. Now, as soon as you start to think about that, it becomes a rather ill-conditioned concept. What do we mean by connection? Do we mean a major fibre bundle like the corpus callosum? Do we mean a single axon in that fibre bundle? Do we mean a single synapse at the end of that axon? Do we mean a bouton on that synapse? Or do we mean a packet of glutamate which is actually sending the message across the synaptic gap? We don't know. But we can define a connectome in this context as being a macroscopic millimetre scale connectome, and in that sense we can measure it with MRI. So this is now the pseudo-anatomical connectome measured by the kind of tracks you saw in that emerging head. And I won't bore you with this, but the larger the blobs are, the more connected the regions are, and the darker they are, the more important those regions are for connecting other regions. And these are mathematical properties now. And the glory of that is as soon as you have mathematics, you can start to do precise science. We're back in the world of number again, and instead of having to guess what our eyes are telling us, we now have precise data we can look at. And just to make a very small point about this connectome, the bigger areas, the most connected areas, are obviously ones like the frontal lobe, superior frontal gyrus, or the superior parietal gyrus. Superior frontal gyrus is where you make your executive decisions. Superior parietal gyrus is where you orientate yourself in space and time. They're big, they're highly connected. Thalamus, on the other hand, is big, but not quite so connected, which is interesting. But if you think about it, it's not surprising because it's sending corticotropic messages out from the thalamus out to the cortex in a fairly stereotyped way. Some areas that you might think will be big are quite small. The occipital lobe, where we do our visual processing, is quite small. Why is that not very connected? Well, probably because it gets one message in from the lateral geniculate nucleus and sends one message out to the association areas. So it's got small numbers of connections. They deal with one thing, not with many things. So this kind of data allows us to start to ask questions about how the brain is developing and how it's growing. We can display this data in a slightly easier way to understand. The pseudo-anatomical thing is great to get the first impression, but it's not very helpful for a further analysis. We can display them in these circles. And where you see the lines in the circles, these are where there are strong connections. And I won't bore you with the details of how they're defined, but they're strong connections. We can then ask, what do other features do to these connections? So these are the connections which are strongest as the children get older, and you'll see they're largely involving the frontal lobes. From our point of view with preterm brain injury, what does prematurity do to these connections? Well, these are the connections now on the right-hand side which are reduced by prematurity. So the lower your gestational age, the lower the connection. And you'll see they're fairly widespread through the brain. Actually, they're not uniform. These are patterned, these connections, and these lack of connections. And learning that kind of data is where we might start to think about how prematurity is affecting our children's brains. And for those of you who actually understand this stuff and are interested in it, this is the formal mathematical representation of the same thing. And what this is telling you is that the connections which are not connected well are the ones between, they're the smaller feeder connections into the main structures. And I'm not going to spend time on that. So I'll finish with something that's not our work. This is a paper that just came out from North Carolina. And it's a paper which purports to do exactly what we've just been talking about, which is to use this kind of connectome data to predict the future. And the graphs you see on the brain diagrams you see are a series of connections which in their study, very small study, only 30 infants, Their study showed a predictive power for the outcome for these preterm babies. And on the right-hand side, two graphs which they say are the relationship between the predictions they made for 2-year-old outcome in these children and the actual 2-year-old outcome in these children. This is a remarkable graph. If it stands up to further scrutiny, it's a very significant achievement and may make a big difference to our futures. So I'm going to finish with that and say well done, North Carolina. I hope it's true. And thank you to my colleagues who actually do all the work. And thank you for listening.